Afternoon. I'll try and go a bit quicker and catch up. I'm going to talk to you today about one of our interventional medicine products. We've got a range on display outside on a tabletop if you're interested in seeing some more, but this one is specifically designed to standardise treatment of liver cancer. And why liver cancer? Well, it's one of the few cancers that is actually bucking the trend and is actually on the increase. It's set to increase probably for the next 10 to 20 years, and actually it's a real killer as well. Mortality rates are high, so it's one to address. And the way in which patients are treated is that they're really treated according to a staging system developed by the Barcelona Clinic for Liver Cancer, where it depends on what point the patient's diagnosed. If they're early stage, then really they're amenable to curative treatments such as resection, liver transplant, or certain ablative therapies. If they're late stage, then it's palliative care. There are some new agents like sorafenib available for these sort of patients, but they have quite severe side effects. The majority of patients probably fall in between. They're intermediate stage, and traditionally they've been treated with a technique called chemoembolization, and I'll go into that in a little bit more detail. So the principles of treating liver cancer with an embolization process is that you use guide wires and catheters in a minimally invasive procedure, usually an entry point via the femoral artery in the leg or in the radial artery in the arm, and you use guide wires to get into the hepatic artery. You introduce a thin tube called a catheter, and you try and get it as close to the liver tumour as possible. Now you can introduce little particles to block the blood supply, embolize the vessels that feed the tumour, and that's called transarterial embolization. Or you can do that by actually making a chemotherapeutic emulsion, delivering that to deliver chemotherapy locally to the tumour and then block the blood supply as well. Traditionally that's done in 2 steps, and that's called a transarterial chemoembolization. And why can you do that in the liver? Well, it's down to the anatomy really. The blood supply to the liver is largely from the portal vein. About 75% feeds the liver, but liver tumours, they derive their blood supply mainly from the arterial supply. So you can go in and block significant amounts of arterial supply with embolization without causing the organ to go into failure. Now, I said traditionally chemoembolization has been done for about 30 years. It involves taking a drug. And drugs, they vary from place to place depending on the hospital and their preference. They use a radiopaque oil that's iodized poppy seed oil actually, that's been around for about 100 years, and they mix it to form an emulsion, and everywhere does this differently, and it is critical the ratios in which you mix if you want to get this to work, because you're trying to trap the drug in the oil. The amount of oil that's used is also variable. Really, although it's been practiced for many years, outcomes from hospital to hospital are very different, and it's really in need of standardisation. And it's then a 2-step process. You introduce this oil, it's viscous, it has the chemotherapy in, and then you follow it with particle embolization to block the blood flow to the tumour. Now, what we developed about 10 years ago now is a way of standardising the treatment by doing it in 1 step. And we've developed some very small polymeric microspheres that can be loaded with the drug. So you can block the blood supply, and then the microspheres deliver the drugs in a sustained fashion, controlled fashion over time. So you're doing it in 1 step and you're standardising the procedure. Now we make the little microspheres. It's quite an interesting process. It's a bit like making your oil dressing with your olive oil and balsamic vinegar. If you mix the 2 and give it a shake, you'll notice you make lots of little droplets of your vinegar in the oil. We do something similar, and then all the little droplets, we cure them so that they're fixed into these microsphere shapes. Of course, we've got all the sizes in one go. We tint them blue so that you can see them. So if you go to the stand and have a look, they're tinted with contact lens dye. Otherwise, they're completely transparent and you can't see what you're handling. And then we sieve them. It's a bit like panning for gold. And we wash them through with lots of water and separate them into size fractions. So that's so the physician can choose the size depending on the arterial supply that he wants to block. Now, we supply the product to hospitals actually without a drug in it. and the microspheres have the ability to sequester drug from solution. So they're a medical device. Actually, that's how they're regulated in the US as just a device. They don't have a label for drug loading. Everywhere else they have a label for drug loading, and we sell it to the hospital, it goes to the pharmacy, and the pharmacy follow our instructions where they make up a drug solution and literally add the solution to the beads, and they wait for about half an hour to an hour. And you see that there's a drug solution with beads in it, and within about half an hour there you can see the beads have turned red and they've sequestered the drug from the solution. Now, these are introduced by interventional radiologists or interventional oncologists. This is, as we said, minimally invasive, image guided. So the picture on the top left is a picture of a physician. He's got what's called a C-arm. You can see why that's called a C-arm. It's got an X-ray detector that can be rotated around the patient. The patient's awake, lying on the bed, and they're looking at the TV screens that show the X-ray images, live X-ray images of the patient and around the liver anatomy. They can use their guide wires, they're metal, so they're able to see where they're going and get into the hepatic artery. And then they use contrast agent, liquid contrast agent that absorbs the X-ray to deliver the microspheres, and they flow into the tumour and block its blood supply. And use the contrast and the flow of contrast to know when you've actually blocked all that blood supply. So if you look at the image on the bottom right, the middle panel shows that sort of egg shape. That's the outline of a large tumour in the liver. You can see all that vascularity around that. That's all the blood vessels feeding that tumour. And then after you've introduced some of the microspheres, you can just see the main hepatic artery, and then the rest of the vessels have disappeared. That's because you've blocked the blood supply to those, and contrast agent can't flow into that any longer. So one of the key features of this versus the conventional technology is that because the drug is trapped within the microsphere and then it's eluted from that over time, probably over for the next sort of couple of months, the amount of drug that's released into the systemic system is very low. So if you look at these pharmacokinetic data from 2 of the first clinical trials, if you look at the top bar, for instance, the 2 little blue and sort of red bars are the maximum systemic dose of the drug that's released compared to the same procedure carried out in the conventional manner. So you can see the conventional manner is not only do you get a lot of drug released into the system, it's also very variable when you look at the size of the error bar. And we've been fortunate to actually treat patients that have actually then undergone a transplant because they've responded quite well and then been able to be transplanted. And in a series of patients, we've been able to then take the liver, analyse it, look at where the beads are, and then measure the amount of drug that's eluted into the tissue. And we can see that the drug does travel a reasonable distance into that tissue and stays at a therapeutic level for at least around a 1 month time frame. And the beads tend to locate, depending on the size, around the sort of periphery and just inside the tumour, which is where the active rim of the tumour is really, because the cancer's more necrotic in the centre and tends to be more aggressive and dividing around the outside. So they target the tumour relatively well. And we looked at a randomised study comparing the conventional method versus the beads. We found certainly significant decrease in side effects, things like your hair falling out, and that type of thing. And also we monitored liver enzyme levels, and you can see when you get a spike, that's indicating some insult to the liver, and you got significantly less liver enzyme spikeage when you use the drug-eluting bead technology compared to the conventional method. And since this has been around for about 10 years now, you can see that some of the data that have been gathered in some of the early studies, we've actually got 4 and 5 year data now for this that with the conventional method wouldn't have reached these sorts of levels, but you're somewhere between 40 and 50% survival. I mean, those are really high survival levels for this type of patient. And of course, with the healthcare system being what it is, you have to think about the cost. Certainly when we launched this product, it was considered a premium product and more expensive than the conventional method. But since then, the manufacturers of the oil have, I think, put about a 10 times premium on that now. which closes the gap. And also their guidelines mean that they have to do 2 procedures because they have to lower the drug dose because of the toxicity. And when you take those things into account, it's more cost effective to do it now with a drug-eluting bead. If you look at this randomised study that was carried out just on the basis of hospital stays, so the fact that the patients tolerate the procedure better and have less hospital stays makes it a more economic procedure to undertake. So where are we going with this? Well, we said we started with bland embolisation, where you just take a device to occlude the blood vessels, and we modified that so that they could absorb the chemotherapy and elute it over a sustained time period, creating the drug-eluting bead. And in this evolution, we're now looking at effects of perhaps adding radiopacity so that we can actually see the beads under the X-ray that they use to do the procedure, because at the moment you can't see them. Perhaps adding biodegradability, because these are permanent implants, so once you've delivered them into the tumour they stay there. And we're also looking at novel drugs, different types of drugs, like the multikinase inhibitors for instance, which could be very good drugs to deliver locally. And just to finish on, I'll show you an image there. This is what we've done to make the radiopaque bead. I can show you this outside as well if you like. Instead of having blue beads now, we've got gold coloured beads, because we've took the blue dye out and we've essentially added a contrast medium that we've attached to the beads. And the picture on the right is a CT image of one of the first patients treated with liver tumours, and all of that vessels that are highlighted there, that's actually beads now in the vessels that you can visualise. So you can now see where you've treated. You can see areas where you haven't treated, and we're looking to see if you can actually then take this information and predict drug coverage and potentially the response to the therapy.